I want to switch gears today and move over to another topic that has been very, very much on my heart for a long, long time. As many of you may know, I work with different directions of, can we call it diagnostic categories? I really believe and hope one day we will move away from diagnosis and simply work on profiles, because I think it's far more respectful to the human being. But that's a talk for another day. But I want to talk about the overlap between autism, ADHD, and dyspraxia. This is an important deal. Over the years, and I've been in practice now for 24 years. And then as an OT, I've been working for about 37 plus years. And all over those years, there's been all kinds of trends from all kinds of frames of references. But what is very disconcerting today is that what I'm seeing is that we are not discerning enough with exactly what are we looking at when we're looking at a certain diagnostic category. When you're looking at autism, the DSM says this is a persistent deficit in social communication and social interaction across multiple contexts. That's the official diagnosis. So it's wide. I mean, if you're looking at that, it could have really be anything. But we do know it's persistent. We do know it's ongoing. We do know it has a social piece to it, right? And because we know that, and that's the sense we make of that, that also overlaps into other areas, like if you're looking at ADHD. ADHD includes also a social piece, but it's really much more about the inattention, the impulsivity, and the disorganization and the executive function that this brings. And so we also know, and we talk about impulsivity quite a lot, right? So I can't wait. It's got to have it now. I've got fleeting thoughts and ideas, and I go from one thing to the other to the other. So you have this flavor, and it's not really about what is autistic and what's not, because really, I want to remain respectful in this whole neurodiverse movement that I agree with, in terms of the fact that we do need to respect each other individual differences. And if I'm talking about certain symptoms, please take it with grace, because it's not that I'm meaning that this is a be all and end all for everyone. There's a wide array of differences in every single category we can ever discuss. And there's a lot of misconceptions. You know, one of the old misconceptions is that autistics don't feel the same feelings as others do. Of course they do. I can tell you of some autistics that I've worked with that have got the depth of feeling that I wish some neurotypicals would have, right? If you want to call it that. So, but what I do think is important is that if we know what drives the profile the most, is it inattention, impulsivity, hyperactivity? Or is it this whole social continuum with this whole neurodiverse profiles that comes into it? Or is it dyspraxia, which is a motor neuron disorder? That's a developmental delay. So there are differences in those three, but because they overlap, and also because the DSM only includes the sensory processing in the diagnostic category of autism, oftentimes kids are getting mislabeled, and it changes how we intervene. When you think about the similarities, all of them are neurodevelopmental. All of them start early in childhood. It's hard for them to be with typical peers, all of them, right? They can look very similar on the inside. They can have similar attention difficulties. There are similarities. But because the outside looks the same, it does not mean that the nervous system that you are trying to change with neuroplasticity work is the same. And that changes where you're going to intervene and how you're going to do your program. When you're looking at the underlying considerations of ADHD, dyspraxia, and autism, ADHD, much more about attention. Dyspraxia, it's about motor planning. Autism, it's a wide array of differences impacting their social communication in a persistent way. The other piece also that we need to bring in is that I've never really felt that I was treating a diagnosis. I think I've said that. And I don't really want to also say that when we talk about intervention, that we're going to be fixing anybody or changing anybody. I have no will or need or want to do that. We are going to accept whatever you bring to the table. We're going to do a nice analysis of what your strengths are, your weaknesses are, and then we're going to use your strengths to improve the weaker areas so that you can find joy in the world, so that you can have the job you want, so that you can have the leisure activity you want, so that you can have the friends you want. It's about coming alongside your client, coming alongside them and saying, I'm going to be there with you on this journey for the time period that you allow me to be there. And I'm going to use whatever clinical knowledge I have to support you. So that's the disclaimer I want you to know. So when I talk about intervention, please don't hear the words fix or anything like that. Because I think there's a couple of things in me that needs to be fixed. But I'm okay with them, right? And so it's not about fixing. It's about the journey and the process of the journey. So when we come back to autism, we think about social engagement. It's difficult for them to be socially reciprocal and in a very even way. You know, the kind of small talk that we engage in may not be as interesting for them, right? There are specific other interests that may garner a far better discourse. And then even in that discourse, it may lack in some fluidity and rhythm, depending on the profile and depending on the continuum of what is available in autism. But when you think about ADHD, it's not like they're not able to socially engage. They just look like they haven't listened to you, like they're just not available in the moment. Their thoughts are going elsewhere. They may talk over you, or they may talk run-on sentences. It could be difficult for them to wait turns. They may often interrupt. They may cause discomfort in a social situation. Wait, Johnny, not now. Mommy, 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 right? It's just like, okay, here we go again. So ADHD's flavor is more that sort of, can I say, that fragmented feel to the social piece. Whereas with autism, it may be the reciprocity piece. It may be the fact that I can't always have that beautiful rhythm turn take, because the topic might not be where I am, and there's a different interest in maybe the discourse and the discussion. Now, if you do a social engagement in dyspraxia, it's not about any of those pieces really at the bottom of it. At the bottom of dyspraxia lies a sequencing and timing difficulty in the nervous system that disallows them to follow the discourse in a group with everybody having a different thought, this one, that one, this one. And I have to follow all of that, keep that in my mind, and keep a cohesive narrative on it. I have to formulate my own sentence, and I have to think about my thought and your thought all in the same time. It's overwhelming. And so what the adaptive response that the dyspraxics do, they often become very rigid or bossy. And they want to control the game, not because they want to be bossy. Please, let's not judge kids if there is a developmental delay. There's no judgment. It's because they are feeling, if you change on me, I can't handle your change. I only know this one way to do it. I can only follow one plan at a time, cannot flex myself out of it. It's a survival mechanism to become bossy. So why is it important? I mean, there's so many other pieces too. I just did a talk for ICDL a while ago, and I talked about this topic, and I was thankfully that it was very well received. But why is it important? Because it changes the game of medication. Can I give a kid a stimulant when they have problems showing their affect and their feelings, when the stimulant may drown it? Can I start with a behavioral program when the child has problem-solving abilities that need sensory integration work to face the challenge of the problem and the new and the novel of it? Do I start working with the nervous system on an angle where in dyspraxia I can figure out, is it auditory vestibular, is it visual vestibular, what is the underpinning, and I can start targeting that immediately in my intervention. If it's autism, I know I can't immediately go there. I will need time to work on safety and security and trust and engagement and joint attention. I would need to work on those things first before I can get to the job of integrating those pieces together. When I'm working with ADHD, I may need to start with the same places that I start with dyspraxia, but I also will know that there's another element at work that helps the hormonal exchange for the attentive purpose. It changes how we intervene. And as clinicians, we have an ethical obligation to families to not waste their time and their funding. Every parent out there wants their child to catch up, wants their child to be in a good space, wants their child to feel like they can go alongside their peers. They need it for themselves as much as they need it for their children. We need to help them to know, what exactly are we looking at? We can't have a 15-minute evaluation and know what it is. We need to assess thoroughly. We need to connect the dots. And that's it for today. Until next time.